Welcome to Pediatric Case Review. Today we present a comprehensive case-based review of Legg-Calvé-Perthes Disease, designed as interactive clinical education for general pediatric physicians. This lecture takes a systematic case-based approach to understanding diagnosis, management, and long-term outcomes in pediatric orthopedic care. We will work through 15 carefully crafted clinical cases. Let us begin. Case Study 1. Evaluation of intermittent limping. A 6-year-old boy presents to your clinic with a 3-month history of intermittent limping, primarily noticed after playing soccer. His mother reports that he has mild discomfort in his right hip that occasionally radiates to the medial thigh and knee area. The limp appears painless and does not worsen with rest. He denies any recent trauma, fever, or systemic symptoms. The child is otherwise healthy with normal growth parameters and no significant past medical history. On examination, the child walks with a mild antalgic gait. Hip range of motion appears mildly limited, particularly with internal rotation. No obvious deformity or swelling is noted. The child appears comfortable at rest. Which of the following is the most likely diagnosis? Option A, transient synovitis. Option B, slipped capital femoral epiphysis. Option C, septic arthritis. Option D, Legg-Calvé-Perthes disease. The correct answer is Option D, Legg-Calvé-Perthes disease. This condition classically presents as a painless or mildly painful limp in children aged 4 to 8 years, with insidious onset developing over weeks to months. Hip pain is often referred to the knee or medial thigh, which is an important clinical trap. The absence of systemic symptoms including fever, trauma, or acute illness distinguishes it from septic arthritis. The radiographic hallmark is a small, sclerotic femoral head with early joint space widening. Key clinical point. This condition is often mistaken for transient synovitis or overuse injury, making early recognition critical for appropriate management and optimal outcomes. Case Study 2. Physical limitations in hip pain. A 7-year-old boy presents with a 2-month history of worsening hip pain and a noticeable limp. He has difficulty running and climbing stairs. The pain is localized to the right hip and worsens with activity. He has no history of trauma. On examination, he has limited internal rotation and abduction of the right hip. He walks with a Trendelenburg gait. Which of the following clinical findings is most specific for Legg-Calvé-Perthes disease? Option A, pain on passive hip flexion. Option B, antalgic gait. Option C, decreased internal rotation and abduction. Option D, fever and systemic symptoms. The correct answer is Option C, decreased internal rotation and abduction. Decreased internal rotation and abduction are highly specific physical examination findings in Legg-Calvé-Perthes disease. These limitations result from femoral head deformity and joint stiffness that develops as the disease progresses. The Trendelenburg gait is caused by pain and weakness of the gluteus medius muscle, and this compensatory gait pattern is more common in chronic or advanced stages. Antalgic gait typically appears in earlier disease phases. An important clinical trap. Hip pain frequently refers to the knee, which can lead to diagnostic confusion. Clinical pearl. While antalgic gait is common in many hip conditions, decreased internal rotation and abduction are highly specific findings that should strongly point you toward this diagnosis. Case Study 3. Peak incidence and demographics. A 5-year-old boy presents with a 4-week history of limping. His mother reports he has been less active at school and avoids jumping activities. He denies significant pain but demonstrates a subtle limp when walking. On physical examination, he shows mild limitation of hip motion and a slight Trendelenburg sign. The remainder of his physical examination is unremarkable, with normal vital signs and no signs of systemic illness. Which of the following best describes the typical age of onset for Legg-Calvé-Perthes disease? Option A, 2 to 4 years. Option B, 3 to 5 years. Option C, 4 to 6 years. Option D, 5 to 7 years. The correct answer is Option D, 5 to 7 years. Legg-Calvé-Perthes disease most commonly presents between ages 5 and 7 years, representing the peak vulnerability period for capital femoral epiphysis injury. This age range is critical for prognosis and treatment planning decisions. Key epidemiological points. The disease is rare before age 3 and after age 12. Peak incidence correlates with the timing of skeletal maturity, and vulnerability relates to blood supply changes during growth. Earlier onset generally indicates a better long-term prognosis. Regarding gender distribution, there is a marked male predominance with a 4-to-1 to 5-to-1 ratio. Boys are significantly more affected than girls, though the reason remains unclear. Case Study 4. Mechanism of gait abnormality. A 7-year-old boy presents with a 3-month history of limping. On physical examination, you note decreased internal rotation and abduction of the right hip. He also demonstrates a Trendelenburg gait pattern during ambulation. His mother reports he has difficulty with activities requiring single-leg stance, such as climbing stairs. Which of the following best explains the mechanism behind the Trendelenburg gait observed in Legg-Calvé-Perthes disease? Option A, weakness of the quadriceps due to disuse atrophy. Option B, weakness of the gluteus medius due to pain and joint instability. Option C, spasticity of the adductor muscles causing abnormal positioning. Option D, acute pain from an underlying hip fracture. The correct answer is option B, weakness of the gluteus medius due to pain and joint instability. The Trendelenburg gait in Legg-Calvé-Perthes disease develops through three key mechanisms. First, pain inhibition causes protective muscle guarding that reduces gluteus medius function. Second, joint instability from altered hip mechanics further compromises muscle effectiveness. Third, the body adopts a compensatory adaptation, reducing weight-bearing stress on the affected hip. The clinical significance of this gait pattern is that it causes the pelvis to drop on the unaffected side during the swing phase of walking, creating a characteristic waddling appearance. It represents a more chronic or advanced stage of the disease. Case Study 5. Muscle atrophy in chronic limping. A 6-year-old boy presents with a 2-month history of limping. On examination, you note atrophy of the right thigh and buttock muscles. He has decreased internal rotation and abduction of the right hip. The child denies significant pain but prefers to avoid running and jumping activities. His gait shows a mild antalgic pattern with reduced stance phase on the affected side. Which of the following is the most likely cause of the muscle atrophy observed in this patient? Option A, nerve root compression from lumbar spine pathology. Option B, intrinsic muscle disease such as muscular dystrophy. Option C, inflammatory myopathy. Option D, disuse due to pain and limited motion. The correct answer is option D, disuse due to pain and limited motion. Muscle atrophy in the thigh and buttock region is a common finding in chronic Legg-Calvé-Perthes disease cases. This atrophy results from prolonged disuse secondary to pain avoidance and progressively limited hip motion. The reduced activity leads to measurable differences in muscle circumference between the affected and unaffected limbs. The atrophy typically affects the quadriceps, hamstrings, and gluteal muscle groups. Circumference differences of 1 to 3 centimeters are commonly observed. An important clinical point: the atrophy is not due to neurological injury or intrinsic muscle disease, but rather a consequence of protective disuse patterns that develop as the child attempts to minimize hip discomfort. Early intervention with appropriate physical therapy can help prevent irreversible muscle loss. Case Study 6. Leg length discrepancy causes. A 5-year-old boy presents with a 4-week history of limping. His parents noticed he seems to favor his left leg when walking and appears slightly shorter on the right side. On examination, you note a subtle leg length discrepancy on the right side, with the right leg appearing approximately 1 centimeter shorter. He has normal range of motion in most directions, but demonstrates limited internal rotation of the right hip. The child is otherwise healthy with normal growth parameters and no history of trauma or previous hip problems. Which of the following is the most likely cause of the leg length discrepancy in this patient? Option A, early femoral head deformity leading to shortening. Option B, congenital hip dislocation. Option C, slipped capital femoral epiphysis. Option D, Legg-Calvé-Perthes disease with coxa valga. The correct answer is option A, early deformity of the femoral head leading to shortening. Leg length discrepancy in Legg-Calvé-Perthes disease results from early femoral head deformity and shortening, primarily caused by subchondral collapse during the fragmentation phase. This structural change occurs as the necrotic bone weakens and cannot maintain its normal spherical shape under weight-bearing forces. The discrepancy is typically mild in early stages, but may progress over time. Subchondral collapse leads to loss of femoral head height, and shortening also affects the femoral neck length and overall limb geometry. This finding often appears later in the disease course and may not be clinically apparent in very early presentations. Critical insight: leg length discrepancy is a structural consequence, not a primary symptom. It reflects the progression of femoral head deformity and helps clinicians assess disease severity. Case Study 7. Pain referral patterns. A 7-year-old boy presents with a 3-month history of limping and right hip discomfort. His mother reports he has difficulty running and climbing stairs. Physical examination reveals limited internal rotation and abduction of the right hip. During passive internal rotation testing, the child experiences significant discomfort. Which of the following is the most specific physical finding in early Legg-Calvé-Perthes disease? Option A, pain on hip extension. Option B, Pain on hip rotation referred to the anteromedial thigh. Option C, crepitus during hip movement. Option D, positive Faber test. The correct answer is option B. Pain on hip rotation referred to the anteromedial thigh. Pain on passive hip rotation, especially internal rotation and abduction, is a hallmark of early Legg-Calvé-Perthes disease. The pain is characteristically referred to the anteromedial thigh or knee, which can lead to misdiagnosis if clinicians focus only on the knee complaint. This finding, combined with a limp, should raise high suspicion for this diagnosis. Referred pain occurs due to shared nerve innervation patterns between the hip and knee. Many children present initially with knee pain rather than hip pain. Early recognition prevents delayed diagnosis and treatment. Clinical Pearl: always examine the hip in any child presenting with knee pain and limping. Remember the saying, the hip does not lie, but it refers. Case Study 8. Primary pathophysiological event. A 6-year-old boy presents with a 3-month history of intermittent limping. His mother reports he has been less active at school and occasionally complains of mild discomfort in his right hip that radiates to the knee. He has no history of trauma, fever, or systemic illness. Physical examination reveals mild limitation of hip internal rotation and abduction. Plain radiographs show early changes consistent with Legg-Calvé-Perthes disease, including subtle increased density of the right femoral head and slight widening of the medial joint space. Which of the following best describes the primary pathophysiological mechanism in the initial phase of Legg-Calvé-Perthes disease? Option A, inflammatory synovitis leading to joint effusion and cartilage damage. Option B, traumatic fracture of the femoral neck causing secondary complications. Option C, osteochondritis dissecans of the femoral head with loose body formation. Option D, interruption of blood supply leading to osteonecrosis of the capital femoral epiphysis. The correct answer is option D, interruption of blood supply leading to osteonecrosis of the capital femoral epiphysis. The initial phase of Legg-Calvé-Perthes disease involves interruption of blood supply to the capital femoral epiphysis, resulting in osteonecrosis. This ischemic event leads to infarction of the subchondral cortical bone, cessation of ossific nucleus growth, bone softening and structural compromise, and loss of mechanical integrity. Key point: the exact etiology remains unknown, but involves a complex interaction of vascular, genetic, and environmental factors leading to femoral head ischemia. Contributing factors include thrombophilia, which is present in approximately 50% of patients, coagulopathies and vascular abnormalities, mechanical stress and repetitive microtrauma, and environmental factors including secondhand smoke exposure. Case Study 9. Identifying disease phases. A 7-year-old boy was diagnosed with Legg-Calvé-Perthes disease 8 months ago. His initial X-rays showed increased density of the femoral head. Recent follow-up imaging reveals irregular fragmentation of the ossific nucleus with a characteristic crescent-shaped radiolucent line beneath the subchondral bone. His symptoms have worsened, and he now has significant limitation of hip motion. The disease progresses through 4 distinct phases: necrosis, fragmentation, reossification, and remodeling. Based on this patient's current imaging findings, which of the following best describes the key pathological event that marks the fragmentation phase? Option A, revascularization with new bone formation. Option B, formation of a dense sclerotic rim around the epiphysis. Option C, reabsorption of necrotic bone and subchondral fracture. Option D, complete resorption of the femoral head epiphysis. The correct answer is option C, reabsorption of necrotic bone and subchondral fracture. The fragmentation phase represents the most critical period in Legg-Calvé-Perthes disease progression. This phase is characterized by active reabsorption of necrotic bone tissue and the development of subchondral fractures, which create the pathognomonic crescent sign visible on radiographic imaging. Key clinical points. This phase occurs 6 to 12 months after initial symptom onset, and its duration typically spans 1 to 2 years. It is associated with peak clinical symptoms and pain, and it represents the optimal window for surgical intervention. The crescent sign indicates subchondral collapse risk. Remember, the crescent sign is a radiolucent subchondral line that signals imminent femoral head collapse, and this is the critical moment for making containment surgery decisions. Case Study 10. Diagnostic strategy for occult disease. A 6-year-old boy presents to your clinic with a 2-month history of intermittent limping. His parents report that he favors his right leg, especially after physical activity at school. He denies significant pain, but occasionally complains of mild discomfort in his right hip area. There is no history of recent trauma, fever, or systemic illness. On physical examination, You observe a subtle antalgic gait. Hip range of motion is mildly limited in internal rotation and abduction on the right side. Plain anteroposterior and frog leg lateral radiographs of the pelvis appear normal with no obvious abnormalities of the femoral heads, joint spaces, or surrounding structures. Which of the following is the most appropriate next step in a diagnostic workup? Option A. Repeat plain X-ray in 3 months and reassess symptoms. Option B. Perform a bone scan or magnetic resonance imaging of the hips. Option C. Order a computed tomography scan of the pelvis and hips. Option D. Initiate physical therapy and observe clinically. The correct answer is option B. Perform a bone scan or magnetic resonance imaging. When plain X-rays are normal but clinical suspicion for Legg-Calvé-Perthes disease remains high, advanced imaging is essential for early detection. Magnetic resonance imaging is the gold standard for identifying early bone marrow changes and avascular necrosis that precede radiographic abnormalities by weeks to months. Magnetic resonance imaging demonstrates low signal intensity in T1-weighted images of the affected femoral head. Bone scan shows a characteristic cold spot with decreased uptake in the necrotic area. Early detection allows for timely intervention and improved long-term outcomes. Plain X-rays may remain normal for 2 to 6 months after symptom onset. Magnetic resonance imaging advantage. It can detect avascular necrosis up to 6 months before X-ray changes become visible. Case Study 11. Prognostic Classification Systems. A 7-year-old boy with Legg-Calvé-Perthes disease is evaluated at the fragmentation stage. Radiographic assessment reveals that the lateral pillar is maintained at greater than 50% of its original height. According to the Herring Lateral Pillar Classification System, what is the most likely prognosis for this patient? Option A. Poor outcome regardless of treatment approach. Option B. Good outcome only with surgical intervention. Option C. Excellent outcome with no risk of deformity. Option D. Good outcome if bone age is less than 6 years. The correct answer is option D. Good outcome if bone age is less than 6 years. In the Herring classification system, Group B lesions with lateral pillar height greater than 50% demonstrate excellent prognostic correlation with skeletal maturity. When bone age is less than 6 years at onset, the remaining growth potential allows for significant femoral head remodeling during the reossification phase, enabling the hip joint to achieve near normal sphericity and congruence. Conversely, when bone age exceeds 6 years, the limited remaining growth provides insufficient time for adequate remodeling, resulting in residual deformity and poor long-term outcomes despite maintained lateral pillar height. Key teaching point: bone age is more important than lateral pillar height in Group B cases. Timing of growth potential determines remodeling success. Case Study 12. Initial management strategies. A 5-year-old boy presents with a 6-week history of intermittent limping and mild hip discomfort. His parents report he has been less active during playground activities and occasionally complains of knee pain after running. Physical examination reveals subtle limitation of internal rotation and abduction of the right hip, with no significant muscle atrophy. Recent radiographs confirm early necrosis stage of Legg-Calvé-Perthes disease with initial sclerotic changes in the femoral head but no fragmentation. The child has normal growth parameters and is otherwise healthy. What is the most appropriate initial management strategy for this patient? Option A. Protective weight bearing with activity restriction and regular monitoring. Option B. Immediate surgical intervention with femoral osteotomy. Option C. Total hip replacement with prosthetic implant. Option D. Long-term casting with hip spica for 6 months. The correct answer is option A. Protective weight bearing with activity restriction and regular monitoring. Non-operative management is the cornerstone of treatment for young patients with favorable prognostic factors. The primary goal is to protect the softened femoral head during the vulnerable fragmentation phase while allowing natural biological remodeling to occur. This approach is most effective in children under 6 to 8 years of age with Herring Group A or early Group B disease. Key management principles include reducing mechanical stress on the affected hip joint, maintaining hip range of motion through gentle exercises, allowing the natural healing process of revascularization, monitoring progress with regular clinical and radiographic follow-up, and avoiding aggressive interventions that may disrupt healing. Evidence shows that bracing and casting provide no additional benefit beyond simple activity modification in protective weight bearing in appropriately selected patients. Case Study 13. Indications for surgical containment. A 9-year-old boy presents with a 4-month history of progressive limping and hip discomfort. He is an active soccer player who has noticed difficulty with running and jumping activities. Physical examination reveals limited internal rotation and abduction of the right hip with mild pain on passive motion. Radiographic evaluation shows changes consistent with Legg-Calvé-Perthes disease in the fragmentation phase. The lateral pillar classification reveals Herring group B and C pattern with partial collapse of a lateral pillar. Which of the following is the most appropriate treatment approach for this patient? Option A, observation with regular follow-up and activity modification only. Option B, use of a hip abduction splint for 6 to 12 months. Option C, femoral varus osteotomy or pelvic osteotomy. Option D, referral for hip arthroscopy and joint debridement. The correct answer is option C, femoral varus osteotomy or pelvic osteotomy. For patients over 8 years old with Herring group B and C classification, surgical containment is the recommended treatment approach. These procedures improve femoral head containment within the acetabulum and significantly reduce the risk of progressive deformity during the critical remodeling phase. Femoral varus osteotomy redirects the femoral head into better acetabular coverage. Pelvic osteotomy increases acetabular depth and improves containment. Surgical timing is crucial and is most effective during the fragmentation phase. The overarching goal is to maintain spherical femoral head shape during healing. Surgical containment works by repositioning the femoral head to ensure maximum contact with the acetabulum during the reossification phase, promoting spherical remodeling and preventing flattening. Case Study 14. Long-term complications. A 12-year-old boy with a history of Legg-Calvé-Perthes disease diagnosed at age 6 presents with new-onset hip pain. He reports activity-related discomfort that worsens with sports participation, particularly during pivoting movements. Physical examination reveals good range of motion, but pain with forced internal rotation and flexion. Recent X-rays show a healed but flattened femoral head with a shortened femoral neck. There are no signs of infection or acute trauma. Which of the following is the most likely cause of his current symptoms? Option A, recurrent transient synovitis. Option B, avulsion fracture of the greater trochanter. Option C, femoroacetabular impingement. Option D, septic arthritis of the hip joint. The correct answer is option C, femoroacetabular impingement. Femoroacetabular impingement is a common late sequela of Legg-Calvé-Perthes disease due to the aspherical femoral head and altered joint mechanics that develop during the healing process. The flattened, irregular femoral head and shortened femoral neck create abnormal contact patterns during hip motion, leading to labral tears from repetitive mechanical stress, progressive chondral damage to the acetabular rim, early onset osteoarthritis often before age 30, and activity-related pain and mechanical symptoms. Key clinical point: the flat femoral head cams against the acetabular rim during flexion and internal rotation, creating pathological contact that damages the labrum and cartilage. This is why pivoting movements are particularly painful in this patient. Case Study 15. Critical prognostic factors. A 7-year-old boy is diagnosed with Legg-Calvé-Perthes disease after presenting with a 3-month history of painless limping. His bone age is determined to be 6 years. He has unilateral involvement of the right hip with no family history of the condition. The radiographs show early fragmentation changes with maintained lateral pillar height. His parents are concerned about long-term prognosis and ask about the most important factor that will determine his outcome. Which of the following is the most important prognostic factor in determining long-term outcome in Legg-Calvé-Perthes disease? Option A, bilateral involvement. Option B, male sex. Option C, bone age at diagnosis. Option D, age at diagnosis, where younger age equals better outcome. The correct answer is option D, age at diagnosis, where younger age equals better outcome. Age at diagnosis is the most critical prognostic factor in Legg-Calvé-Perthes disease. Children diagnosed before age 6 have significantly better long-term outcomes, with up to 85% achieving normal or near normal hip joint function. Clinical significance points: bone age is more accurate than chronological age for prognosis. Younger patients have greater remodeling potential during the healing phase, and the extended growth period allows for better femoral head reshaping. Early intervention in young patients maximizes treatment effectiveness. Critical age threshold: patients under 6 years at diagnosis have an 85% chance of excellent outcomes compared to only 40% for those over 8 years. This data underscores why early recognition and referral are so important in clinical practice. We would like to take a moment to introduce you to the Pediatric Case Review Patreon community. This platform is designed to elevate your pediatric clinical expertise through comprehensive, structured education resources. All videos are systematically arranged by medical system for easy navigation and focused learning, covering cardiology, respiratory, musculoskeletal, and all other major systems. The complete resource library includes high-resolution presentation slides available as downloadable images for offline study. The community also provides extensive practice through thousands of case-based multiple-choice questions with detailed explanations, and all content is expert-curated and evidence-based, designed for clinical excellence. If you are ready to advance your pediatric knowledge, comment below this post for subscription details and next steps, and we will message you directly. We have now completed our comprehensive case-based review of Legg-Calvé-Perthes disease. Through 15 evidence-based cases, we explored the subtle early signs of painless limping, the specific physical examination findings of decreased internal rotation and abduction, the 4 phases of disease progression from necrosis through remodeling, diagnostic imaging strategies, including when to proceed to magnetic resonance imaging, the Herring lateral pillar classification system and its prognostic implications, conservative versus surgical management decision-making, and long-term complications such as femoroacetabular impingement. Remember, early recognition and timely intervention are the cornerstones of successful management, and age at diagnosis remains the most critical prognostic factor. Please follow Pediatric Case Review for more comprehensive, case-based medical education covering all pediatric systems. If you have questions, drop them in the comments below. We read and respond to every inquiry.